Hello, and welcome to the CCO Medical Specialties Podcast. I'm your host, Jill Frost. Today's episode features two experts, Dr. Brett M. Elicker, Professor of Clinical Radiology and Chief, Cardiothoracic Imaging Division in the Department of Radiology and Biomedical Imaging at the University of California, San Francisco, and Dr. David E. Griffith, Professor of Medicine in the Division of Mycobacterial and Respiratory Diseases, Department of Medicine at National Jewish Health. They discuss the pathophysiology of non-cystic fibrosis bronchiectasis, the patient burden, and best practices in diagnosing this disease. This episode is part of a larger educational program titled The Road to Victory Over the Vortex, Innovations in Non-Cystic Fibrosis Bronchiectasis. For more information on Drs. Elicker and Griffith, along with a link to the larger education program, please visit the show notes for this episode. Now let's get started and hear what the experts have to say about this important topic.
Non-cystic fibrosis bronchiectasis is relatively newly described process, but has been around for centuries. It's only that it took the introduction of chest CT scanning to allow more frequent and early diagnosis of the disease. We believe there is a rising disease burden, perhaps over 500,000 U.S. adults and 70,000 newly diagnosed cases per year. The prevalence increases with age to about 70 cases per 100,000 population in adults older than 65 years of age. I would add that if you have particularly a female with the characteristic morphotype for patients with bronchiectasis and a chronic cough, that prevalence probably goes very much higher. The diagnosis is made almost always with high-resolution chest CT scanning, but there is a considerable delay in the time from when a patient develops symptoms to when bronchiectasis is diagnosed. It can be as high as 12 years. And unfortunately, there are fragmented care pathways between specialties, some patients going to pulmonary, some to infectious disease, and at least until recently, therapeutic options have been limited. So in terms of diagnosing bronchiectasis, obviously, like any other disease, there has to be some diagnostic suspicion. And there are a number of tests that can be done, but the one that's most important are the ones that include chest radiography. Usually first a simple or plain chest radiograph, followed by chest CT scan. And then underneath the diagnostic tools are how you might evaluate the cause of bronchiectasis in your patients. And not all patients require all of these tests. But this is a pretty good general guide. I would only say part of the reason that the delay in diagnosis is as long as it is because patients with chronic cough do not get radiographic evaluation in a timely fashion. The pathophysiology of bronchiectasis, it was first introduced a few years ago with the vicious cycle of inflammation in the lung, and now it has become a vicious vortex. But the reason that occurs is that each one of these factors, airway dysfunction, the inflammatory response, infection, and structural disease, has a feedback to each of the other aspects of the vicious vortex. So everything serves to perpetuate a self-perpetuating cycle of airway inflammation. And interrupting that is actually rather complicated. There are now phenotypes and endotypes of bronchiectasis where even 5 years ago, those concepts were not widely appreciated. In terms of the functional endotypes, you're looking at underlying inflammatory and immunologic mechanisms, and probably the most important of those is a subgroup of bronchiectasis patients with eosinophilic inflammation. Those patients respond better to bronchodilator medications than the neutrophilic inflammation, that predominant inflammation. And then you have phenotypes I'm sure you're all familiar with: daily sputum production, infection by Pseudomonas, mycobacterial lung disease and some patients who cough up very little sputum. But neutrophilic inflammation appears to be the central driver for the majority of patients with non-CF bronchiectasis. And one pathway for that inflammation, that self-perpetuating inflammation, is release of serine proteases by neutrophils. And a substance called DPP1 activates those neutrophil serum proteases. This type of inflammation is associated with frequent exacerbations and decline in pulmonary function. This is actually a rather potent stimulus for a self-perpetuating cycle of inflammation in the airways of patients with bronchiectasis. Symptomatically, patients almost universally have cough. It is by far the most important or the most frequent symptom. Dyspnea is very common. Sputum production does not occur in all patients, but it does occur in the majority. And one that's not on here is fatigue. Patients, again, almost universally feel fatigued. They also have quality of life and socio-emotional distress. It is very taxing for a woman in her 70s to have chronic cough. That is anathema to many women in that age group, and very distressing when it occurs in public. There is both a high hospitalization rate and a high economic burden. I'd like to look at the results of a survey and a focus group related to non-cystic fibrosis. Since it was 18 patients in the survey, and 10 patients shared their experiences in a moderated online focus group. Just to highlight a few things, we've already mentioned that most patients are diagnosed after a significant period of time, but this is very important. 55% rated their understanding of bronchiectasis as either fair or poor, and only 6% felt it was excellent, and only 12% said treatments were working very well. Just to pause 1 second, what I am struck with most from patients referred to National Jewish Health is the lack of understanding of what is bronchiectasis. What does it mean? I'm always surprised many of the patients have the belief that bronchiectasis is a terminal diagnosis, and are very relieved to learn that it actually, particularly in people with mild disease, does not affect life expectancy. However, having said that, I think it is extraordinarily important for the diagnosing physician to spend a little time explaining what bronchiectasis is, perhaps showing an example of it on a chest CT scan, and then working through the management of bronchiectasis. So a few takeaways. Patients with bronchiectasis have to understand that this is a chronic disease. It's not going to go away, and that they are going to have to deal with it in a long-term basis, and understand the financial and social burdens it places on them. And those sorts of things are actually underappreciated during brief clinic visits. One other thing that I think is just as important as explaining the disease is discussing airway clearance techniques. The majority of people who come to National Jewish with a diagnosis of bronchiectasis have not been taught airway clearance techniques. Frequently, they're advised simply to go to YouTube and see what is available there. I understand respiratory therapy is very difficult to come by, even in some urban areas, but for bronchiectasis, there just is no replacement for adequate respiratory therapy and airway clearance technique teaching. Patients are diagnosed frequently with obstructive lung disease, either reversible or non-reversible, and frankly, it's often misdiagnosed as one of these obstructive lung disease phenotypes. And as we've talked, you have to have radiographic imaging to make a diagnosis. In terms of management, one other aspect of management that we frequently see is the use of inhaled corticosteroids, usually because patients are misdiagnosed as having asthma or some other bronchospastic disease. But there is pretty good information that the inhaled corticosteroids potentiate the progression of mycobacterial disease. There's also underuse of inhaled antibiotics for Pseudomonas. Anybody with bronchiectasis should be taught airway clearance. Now, it may prove to be ineffective, but for the majority of patients, this is the foundation of management. And then use of long-term anti-inflammatory medications like macrolides, and then with more advanced disease treatment of Pseudomonas, treatment of non-tuberculous mycobacteria. But this is essential. And unfortunately, as we've just discussed, it is unavailable to many physicians and their patients because of a lack of respiratory therapy. I will point out those patients with eosinophilic inflammation may do well with some biologics. You have to be a little bit careful with those in patients with mycobacterial disease. And with that, I want to close that portion of our talk and turn things over to my colleague, Dr. Brett Elicker.
Well, thanks so much. So, as Dr. Griffith mentioned, CT is very sensitive and specific for bronchiectasis. And the things that we're looking for are enlarged airways. And we're going to talk about the criteria for calling an airway enlarged. And of course, these are often associated with other signs of inflammation, which may be thickening of the wall, mucus plugging. If you have involvement of the distal airways, you can see clustered central lobular nodules and tree and bud. And we'll talk more about the sort of criteria for calling bronchiectasis on a chest CT in just a minute. And of course, chest x-rays are often obtained and are often the first test that's obtained, but the sensitivity of CT is way better than chest x-ray. And this is a patient with really a severe childhood viral infection that resulted 50 years later in very advanced bronchiectasis. You can see these kind of circular opacities with air fluid levels in them, but you're not going to detect bronchiectasis on a chest x-ray until it's quite advanced and down the road when potentially treatment might have been effective early on in slowing the progression of disease. So as Dr. Griffith mentioned, have a low threshold for obtaining chest CTs. Now, of course, there are different diseases that affect different levels of the airways. And certain diseases tend to affect more of the large airways, and other diseases tend to affect more of the small airways. And you're going to think about a different spectrum of disease depending upon which one is most affected. And of course, there's overlap, but usually certain diseases affect predominantly one or the other. Large airways are what we're talking about today: bronchiectasis, airways inflammation, mucus impaction. The findings of small airways disease are more clustered central lobular nodules, tree and bud opacities, and bronchial ectasis, where the airways are dilated very distally in the lung. And again, there's overlap between the different causes of predominantly large airways versus predominantly small airways disease. Again, certain diseases tend to affect more of the large airways or more of the small airways. So the first question when you're seeing this is, what's the predominant size of the airway that is involved by the disease? And that helps you with your differential diagnosis. CT, very sensitive and specific. It's really a great test for detecting and characterizing bronchiectasis and the diseases that cause bronchiectasis. It is also, obviously we get this often at the beginning, but we also do serial CTs over time to monitor changes, what's happening, what's the direction of changes. Are the airways getting more dilated, or are we actually showing improvement in the degree of inflammation? Do we have worsening findings of inflammation or improvement? And then are there any other superimposed findings in patients with acute or more worsening symptoms? So a really good test to detect the initial bronchiectasis and then follow it over time and detect those changes over time. So here's the sort of deeper dive into what we call bronchiectasis on CT scan. The simplest is the bronchoarterial ratio. And that's just measuring the internal lumen of the bronchus, the airway, compared to the adjacent artery, which is right next to it. And that bronchoarterial ratio classically in normal is less than 1. Definitively abnormal is greater than 1.5. And then there's this sort of gray area in between of 1 to 1.5. There are a couple papers that actually show that normal people who are older, over the age of 60 or 70, and people who live at elevation, where Dr. Griffith is in Denver, might have a bronchoarterial ratio normally between 1 and 1.5. In that gray area, you look for other findings to help you. Is there airways inflammation? Is there mucus impaction? Is there tree and bud? So that's the simplest way. Now, obviously, some other features that we look at are this lack of tapering. You should not really see airways that last 1 to 2 centimeters of a lung. If you do, there's probably some problem with the airways. So these are the findings you're looking for on CT to find bronchiectasis. Now, we want to distinguish, there's different types of bronchiectasis. There's inflammatory bronchiectasis, which is the topic of today. And then there's traction bronchiectasis, which is merely a manifestation of lung fibrosis. That's not what we're talking about. And traction bronchiectasis is seen in things like idiopathic pulmonary fibrosis or fibrotic hypersensitivity pneumonitis. So the goal today is to talk about inflammatory bronchiectasis. The airways are dilated, but they're also inflamed with a lot of mucus impaction, airway wall thickening, whereas traction, the airways are dry. There's nothing inside of them. They tend to be dilated, corkscrew shaped, and you'll see other findings of lung fibrosis, such as reticulation and honeycombing. So that's a very important decision point in terms of differential diagnosis. Now, there are also different subtypes of inflammatory bronchiectasis, and the classic imaging descriptions of the airways that are dilated due to inflammatory bronchiectasis are cylindrical, varicose, and cystic, and that's in order of severity and chronicity. And the differential diagnosis for cylindrical bronchiectasis is really broad. You can just see that with acute viral infections occasionally. The differential of varicose and cystic becomes more and more narrow because there's a limited number of diseases that produce both severe airways inflammation that lasts for years. And that's what it takes to get cystic bronchiectasis. So again, the differential goes from being very broad for cylindrical and being much more focused for varicose and cystic bronchiectasis, because the cystic in particular implies severe airways inflammation that lasts for many, 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 usually years. And so once we have those more severe forms of bronchiectasis, we look at the distribution and associated findings in terms of thinking about the diseases that cause them. Classic, we're not focusing on cystic fibrosis, but the classic, we need to know what it looks like. The classic cystic fibrosis is symmetric and upper lobe. The other big one that we deal with regularly is non-tuberculous mycobacterial infection. That classically has a middle lobe lingular predominance. There are different subtypes or different manifestations of NTM, but this is the most common. What we often see collapse, partial collapse of the middle lobe and lingula. There's lots of airways inflammation, but there's very little disease outside the airways. So consolidation, typical findings of pneumonia, like a bacterial pneumonia, are not usually seen in these patients. And there's really very little else that does this. When you have varicose and cystic bronchiectasis predominating in the middle lobe and lingula, it's almost always NTM, very specific. And then there's a group of diseases that often manifest as symmetric lower lobe predominant bronchiectasis, including immunodeficiency, recurrent aspiration, primary ciliary dyskinesia, which I think is under-recognized. And then we'll talk more about in a second, longstanding constrictor bronchiolitis. So that's helped again, distribution can be very helpful in differential diagnosis. A couple other diseases to think about: allergic bronchopulmonary aspergillosis tends to produce really dilated airways that are right around the hilum. And they tend to be kind of not very extensive and diffuse unless the disease is very severe, but you see one airway over here, one airway over there, one airway over here, right around the hilum, really dilated and mucus impacted. We also tend to see high attenuation mucus. The mucus is actually much denser than typical mucus because of, I think it's something to do with how the calcium ions are accumulated in the aspergillus itself. And you can see when you treat this, often the airways inflammation gets a lot better, but the bronchiectasis may persist. And the other disease that you may see occasionally is cartilage disorders, particularly Williams-Campbell and tracheobronchomegaly. And while those are rare diseases, you want to find them and detect them. And they have a sort of characteristic appearance of the airways are very dilated and irregular, but they're pretty thin-walled, and there's not a lot of mucus impaction. And that tends to imply some problem with the cartilage itself. We see this also in patients with other inflammatory diseases that produce bronchiectasis that have been effectively treated. I think probably the most common we see these days are cystic fibrosis patients with these targeted therapies. And once they go on the therapies, the mucus and airways inflammation kind of gets a lot better. So it may look like this, but if you're seeing some patient from the beginning who has significant bronchiectasis, but the airways there's a real paucity of inflammation, think about one of those cartilage disorders. The last disease or pattern of injury I want to talk about, which I think is really under-recognized, is constrictor bronchiolitis. And this is a great example of Cole's vicious cycle or vicious vortex. My son's name is Cole. For me, Cole's vicious cycle is he asks me for money, and I give it to him, and he spends it, and then he has no money, and then he asks me for more money. So that's the cycle that I think about. But anyway, so Cole's vicious cycle in constrictor bronchiolitis, you have scarring, right? Constrictor bronchiolitis is scarring around your distal airways, occurs a variety of different causes, but one of the more common ones is childhood viral infection, and particularly adenovirus. That scarring prevents you from ventilating well, and it takes a lot of pressure to ventilate. And I think the theory is you trying to ventilate through this obstruction in your distal airways, and then that starts to affect the large airways, actually. So that large airways disease becomes worse. Those large airways start to balloon out and get more and more inflamed. You enter that vicious cycle. So this is an example of rheumatoid arthritis with constrictor bronchiolitis. And you can see baseline, the lung density just looks sort of heterogeneous, but over time you start to get bronchiectasis, and that may become quite severe over usually decades. So this is one potential cause of bronchiectasis, and one to think about, particularly in patients when they have the sort of evolution on CT over time and with a history of childhood viral infection, rheumatoid arthritis, Sjogren's disease, things like that. And then, of course, I think it's really important to get expiratory CT, at least on the first CT scan you get in suspected bronchiectasis, because this can really improve your sensitivity for diseases or patterns like constrictor bronchiolitis. And so we've found that adding expiratory CT increases your sort of yield for findings airways disease by about 10 to 20% in that range. So it really does improve your detection of airway obstruction. And obviously air trapping is often a finding of small airways disease, but you can sometimes see it with large airways disease as well. CT is really sensitive for detecting airways disease, both small and large airways disease, and also really narrowing your differential diagnosis using a combination of the findings of the airways disease themselves and the pattern of those findings within the lungs. And as Dr. Griffith said, have a low threshold for getting a CT with suspected airways disease. It allows you for earlier detection and intervention, which actually really, the trajectory of these patients changes significantly once you've found it and are able to treat it. I think in terms of protocols for high resolution chest CT, we want a thin sections, at least 1.5 millimeters or smaller. We do usually 2 series, one with full inspiration, one those expiratory images. And I would say these days, the majority of our chest CTs are at this slice thickness of 1.5 millimeters or less. So a standard non-contrast chest CT in most places is just as good as a high resolution chest CT. The only thing high resolution adds is the addition of the expiratory images. So radiologists are important in sort of detecting this and in being a part of this really multidisciplinary approach to these patients with suspected airways disease.
Thank you, Dr. Elicker and Griffith, and many thanks to you, our listeners, for joining us. As a reminder, to view the full program, The Road to Victory Over the Vortex, Innovations in Non-Cystic Fibrosis Bronchiectasis, please click the link in the show notes. And be sure to check back regularly for more episodes on important medical specialties topics.